it's pervasive. And I will say to you that it's one of the diseases that takes over not just the individual's life, but the family life, right? It's just not a disease. It's not like a little high blood pressure and you just take a pill and check your blood pressure and you go on your day. It is a disease that just literally invades the family household, the family life, the family dynamic. And so I get that concept. We're transforming Alzheimer's dementia from a terminal disease, Alzheimer's disease, from a terminal disease to a chronic disease. But that's not sufficient. You need to be able to make biomarker confirmation. And this is critical, critical, critical. And I say this to you because we have the opportunity now to improve the specificity and sensitivity of a clinical diagnosis to well north of 90%. This is not a research paradigm. This is now clinically applied. You have the opportunity to do amyloid PET. You have the opportunity to do CSF detection. And I want to say to you that amyloid PET is a binary test. It's you either have amyloid in your brain or you don't. It's very accurate, but it is not covered or reimbursed by most insurance, certainly not by Medicare. It's very expensive, to the tune of $5,000 US, and it's almost never used, despite the fact that most people not realize that amyloid PET has been approved since 2013. Fluor-beta-PEA was approved in 2013, fluor-beta-beta in 2014, flutamidamol in 2015. These technologies, these ligands have been approved, but just not clinically used, and that's been a challenge. CSF testing actually has been around for 2 decades, but the newer platform, particularly the Alexis platform, has very, very good specificity and sensitivity. Now, people say to me, and so what I'm saying to you is that this has become a relatively easy way to get a diagnosis. It is invasive, and I'll talk about that in a second, and it is very accurate. Now, people say to me, "Ooh, I don't want to do a spinal tap." And I have to say to you that this hesitation or this concern is wholly arbitrary, and I'm not sure why. When you actually really step back and think about lumbar puncture, in a neurology business, in inpatient, outpatient neurology practice, if a patient walks in the door and they have a headache and a fever and the suspicion is meningitis, of course you're getting a lumbar puncture. If there's a suspicion of a subarachnoid hemorrhage, of course you're getting a lumbar puncture. If there is if you're trying to do a diagnostic workup potentially for multiple sclerosis, of course you're getting a lumbar puncture. My point is that we do lumbar punctures for a variety of neurological disease, half for decades. Why don't we just add Alzheimer's disease to that list? And I think that's where the field is going. And I think that, the fact is that it's relatively quick. With the Sprott needle nowadays, we can be in and out of the back in 5 minutes with a low headache incidence. So the historical perspective on lumbar puncture was it had a 20% headache incidence. With these new Sprott needles, these fenestrated Sprott needles, it's down to 1 or 2%. And I've done hundreds of these with the Sprott needle and have maybe less than 5 headaches on I can count the number of headaches. So it has become quick. It's become easier to attain with low complications, low side effects. And I will say to you, the CSF testing, which includes amyloid and tau, both phosphorylated tau and total tau, and now the Alexis ratio, you do this, you send it to the Mayo Clinic and they send you back a report, gives you the A beta 42 to tau ratio, and it's very, very accurate. And I'm spending time talking about this because I believe that in the push comes to shove, I think that CSF testing may prevail over PET. I think everybody prefers PET, but I think CSF testing is going to become more widespread. It'll become more quicker. You can get a result back in under 5 days, and it gives you more than a PET in terms of having 3 proteins as one. And so I believe that biomarker incorporation will include either PET or CSF, but probably CSF more likely. To the physicians that will be asked by their patients about ARIA, these are the things I would say. Number one is that it doesn't happen very often. It happens a minority of the time and not the majority of the time. Number two is that most of the time it is asymptomatic and not clinically detectable. Number three is that it is manageable. It doesn't last very long. It's transient. and that after a few weeks, you can resume treatment. So I'm saying to you that it is an expected, infrequent complication, but not a deal breaker.